Bismillah ar-Rahman ar-Rahim. This is Dr. Adham Abdeltawab. Welcome to the third part of our lecture about hypertension. We will be talking about resistant hypertension and hypertensive crisis. Our intended learning outcomes for this lecture are to define resistant hypertension, to recognize the causes of true and pseudo resistance, to understand clinical algorithm of management of resistant hypertension, to differentiate between hypertensive emergency and urgency, and to recognize the clinical manifestations of hypertensive crisis and advise required further investigations, describe management of malignant hypertension. Resistant hypertension is defined as the blood pressure that doesn't fall below 140/90 mm mercury despite appropriate lifestyle measures plus 2 antihypertensive drugs of different classes at adequate doses plus a diuretic. It can be a true resistant hypertension or a false or pseudo resistance. If persistent, especially in high-risk groups, it can be complicated by increased target organ damage and increased cardiovascular risk. Resistant hypertension can have many causes. Most commonly it's caused by white coat effect or over anxiety to presence with a doctor, physician. It can be due to patient management issues like incorrect blood pressure measurement or like physician inertia, inappropriate drug regimen, insufficient drug doses. It can be due to adherence issues from patient and compliance issues like complicated regimen and dosing, financial issues, drug side effects, lack of disease perception, and insufficient patient education. It can be due to undetected secondary hypertension, like with renal parenchymal disease, renal artery stenosis, primary hyperaldosteronism, thyroid disease, Cushing syndrome, pheochromocytoma, and aortic coarctation. It can be due to conditions affecting blood pressure control, like obstructive sleep apnea, chronic kidney disease, significant obesity, high salt intake, and high alcohol consumption. It can be drug-induced resistant hypertension, like with the chronic use of non-steroidal anti-inflammatory drugs, oral contraceptives, corticosteroids, sympathomimetics like decongestants, erythropoietin, cancer drugs, cyclosporin, cocaine, licorice, and ephedra. Routine investigations needed for all patients with resistant hypertension are urine analysis, complete blood count, serum electrolytes, renal function tests, blood sugar, thyroid function tests, lipid profile, and 12-lead ECG. And for selected patients, chest X-ray, ambulatory blood pressure monitoring for detection of white coat hypertension, echocardiography, renal ultrasound, renal artery duplex, urinary catecholamines, urinary cortisol, dexamethasone suppression test, plasma renin activity, and plasma aldosterone may be used. The clinical algorithm of management depends on evaluation of the patient to exclude pseudo-resistance by out-of-office blood pressure measures and adherence evaluation, and optimize 3-drug regimen with appropriate doses and appropriate combination, assessing and managing secondary causes of hypertension, comorbidities, and concurrent medications. If the patient continues to have uncontrolled blood pressure, this patient is a patient with true treatment-resistant hypertension. This is managed by endorsing lifestyle measures like weight loss, salt intake reduction, and optimizing drug regimen with agents, doses, through correct intervals, and adding a fourth drug, preferably a spironolactone. Then, if failed, consider interventional treatments if persistent true drug resistant hypertension after 6 months. Second part is about the hypertensive crisis, which can be either de novo or exaggeration of a pre-existing primary or secondary hypertension. This can be a hypertensive emergency or malignant hypertension or hypertensive urgency. The emergency is a blood pressure more than 180/110 plus symptoms or signs of end organ damage. For example, heart failure, pulmonary edema, papilledema, encephalopathy, neuropathy with proteinuria. This is to be managed by ICU and IV therapies. Whereas urgency is a blood pressure more than 180/110 without symptoms and signs of end organ damage. This can be managed by oral treatment with or without hospitalization. Gradual lowering of blood pressure is recommended. Absolute level of blood pressure may not be as important as the rate of increase. The pathophysiology for malignant hypertension is mechanical stress on the vessel wall from pre-existing hypertension, causing vascular injury and accelerated microvascular damage and endothelial damage, the necrosis in the walls of small arteries and arterioles called fibrinoid necrosis, release of vasoconstrictor substances, compromised cerebral and renal perfusion, tissue ischemia, activation of clotting cascade with intravascular thrombosis, pressure natriuresis results in volume depletion and activation of the renin-angiotensin aldosterone system and release of vasoconstrictor substances from the kidney. Its manifestations are usually the manifestations of associated end organ dysfunction, like hypertensive encephalopathy manifesting by headache, altered level of consciousness and or focal neurological signs, manifestations of dissecting aortic aneurysm like acute chest pain with high blood pressure, acute ischemia, left ventricular failure and pulmonary edema, eclampsia, acute renal failure, symptomatic microangiopathic hemolytic anemia. Aim of drug therapy for malignant hypertension is immediate controlled reduction for blood pressure to prevent progressive end organ damage. Pharmacological treatment is needed with either esmolol, phenol-dopam, labetalol, nicardipine, or sodium nitroprusside. It's not recommended at all to use sublingual nifedipine, which is neither safe nor efficacious, because sudden, uncontrolled and severe reduction in blood pressure occurs and it may precipitate cerebral, renal and myocardial ischemic events, especially in the elderly, and it should be abandoned because it is neither safe or efficacious. Nitroglycerin also shouldn't be used. It is a potent venodilator rather than an arterial dilator. It undesirably decreases preload and cardiac output if needed. For example, in patients with acute pulmonary edema or acute coronary syndrome, an adjunct of antihypertensive infusion should be added, and it shouldn't be depended upon like the sole antihypertensive. Also, it's not recommended to use hydralazine due to prolonged, unpredictable antihypertensive effects, and its circulating half-life is only about 3 hours. Prolonged effect on blood pressure up to days. Also, unneeded diuretics worsen the state of volume depletion and only given in cases of associated volume overload as with acute pulmonary edema. Thank you.